Hi, this is Marty Stempniak with a look at the March issue of Hospitals and Health Networks. With the frantic pace of change in healthcare, many independent hospitals are being forced to consider joining or affiliating with other providers. Our cover story this month explores whether it's still possible for these community hospitals to remain independent. Managing editor Bill Santamore has the details.
Our March cover story by Hayden Bush asks whether it's still viable for any independent hospital to remain that way. The answer, it turns out, is yes, it's possible to remain independent, but even then, affiliations of one sort or another will be necessary. They might be tightly drawn, such as outright becoming part of a system, or loosely based, such as strictly clinical partnerships in which you draw on each other's expertise and reputation in certain areas. The need for some kind of affiliation is largely related to shrinking reimbursements and the focus on pay for performance. Outcomes have to be measured, which requires expensive IT systems with a skilled staff. Quality must be demonstrated across the continuum, which means working closely with physicians and pre- and post-acute care providers, and distributing bundled payments with all providers involved in a patient's care. And of course, tighter reimbursements mean hospitals need to build greater efficiencies into their operations. And sometimes that's best accomplished by partnering with other systems or hospitals. When debating whether to remain independent or become a partner, hospitals must consider how strong they are in 4 key areas: operations productivity, revenue cycle, supply chain, and IT. And hospital leaders must understand that partnering in any way will be best for their institution, even if it means they themselves might have to give up some financial or governance control. In a sidebar with the story, Hayden considers the special problems that critical access hospitals face in meeting the demands of accountable care, even as they face the possibility of losing cost-based reimbursements.
Next up, Bill discusses the second installment in our year-long series, Generations in the Workplace, which explores the challenges hospital leaders face in managing a workforce that, for the first time ever, has 4 generations working side by side.
In another feature, the second installment of our year-long series that we call Generations in the Workplace, writer Laura Putri looks at how some hospitals are dealing with tensions among their clinical staffs related to age. As Laura pointed out in her opening piece in January, this is the first time in history that 4 distinct generations of employees are working side by side in hospitals. And Gen Xers and Gen Yers bring different work habits and lifestyle expectations with them than baby boom doctors or nurses might. These can relate to work hours, technology, communication with each other and with patients, or just about anything else. Inevitably, resentments and tensions may arise, and hospitals like St. Luke's Medical Center in Boise, Idaho, are working proactively to ease that tension before it seriously affects the organization.
And finally, this month's Gatefold story takes a closer look at the projected physician shortage in primary care, and how hospitals are increasingly using nurse practitioners and physician assistants to fill that gap. These clinicians can perform some of the same duties as doctors, free up physicians to spend more time on the patients that need the most attention, and help to better coordinate care. The supply of these professionals is expected to grow in the coming years, and some studies have shown that using nurse practitioners or physician assistants as part of the care team can yield equal or better results. For these stories and more, be sure to check out our March issue. For H&HN, this has been Marty Stempniak.